speaker also joining us. Without much delay, I humbly invite Dr. Sunil Kumar MM, the Director in charge of TIPS, the flagship organ of Pallium India, to further facilitate the proceedings of this wonderful session. Dr. Sunil, it is over to you.
Thank you, Sripriya, and good evening, everybody, for all of those from India. And I also understand that there are many people who are joining from different parts of the world. So, good morning to Harvey, and good afternoon, everyone, and a warm welcome to the webinar on dignity in care. So, it is truly heartening to see that a lot of people has joined from different parts of the world, and they include doctors, nurses, medical social workers, psychologists, volunteers, and many others who dedicate their time and expertise to providing compassionate care. And your presence here speaks volume about your commitment as well as to uphold the dignity in every aspect of caregiving. So before proceeding, I would like to speak a few words about Valley Media. And um, I am very proud to be part of Valley Media. Um, and at Valley Media, our vision is very simple, but it uh, profound. It is to stop needless health-related suffering so that people can wake up to life, love, and hope. And many of you know that this organization, Palimedia, is founded by Dr. M. R. Rajagopal. And we believe that every individual, regardless of illness or circumstances, they deserves care that not only addresses their physical pain, but also their emotional and social well-being. And as we know, the theme of today's webinar is dignity in care, which aligns closely with our mission. We believe that every individual, regardless of their illness, background, or circumstances, deserves to be treated with respect, compassion, and dignity. Through education, advocacy, and service, we work to transform healthcare into a more humane and person centered care. And the goals of this two sessions is that to deepen our understanding about dignity, so and how it impacts our patients and caregivers, and explore practical strategies to integrate dignity into our daily interactions. It might be through communication, decision making, or just our presence with patients and their families. And we also encourage the reflection on ethical, emotional, and psychological dimensions of dignity in care, ensuring that our patients feel valued, respected, and heard. And so, uh, I would like to introduce our faculty for today for this webinar. And it's my absolute privilege to introduce Dr. Harvey Chochinov, a globally renowned doctor and founder of Dignity Therapy. Dr. Chochinov is a distinguished professor of psychiatry at the University of Manitoba, Canada, and his groundbreaking work has transformed how we understand and uphold dignity in healthcare. His research on dignity in the context of end of life care has shaped clinical practices worldwide, helping patients find meaning, comfort, and a sense of personhood, even in their most vulnerable moments. So, um, through this dignity therapy, he has provided a structured approach for patients to share their life stories, values, and reflections, ensuring that their voices are heard and honored. Dr. Harvey Chochinov's latest book, Dignity in Care, The Human Side of Medicine, was recently released in India at an affordable price. And I would encourage you, all of you, and I would encourage all of you to buy this, which will give you invaluable insight um, into the dignity therapy and dignity in care. And we are truly fortunate to have him with us today to share his insight and expertise. Please join me in welcoming Dr. Harvey Chochinov. So, welcome, Dr. Harvey, and it's over to you.
Thank you so much, Sunil. Very much appreciated, and thank you for the kind introduction. So I'm going to first off share my slides. Okay. Okay, can everybody see the slide?
Yes, it's visible.
Excellent. So again, I'd like to say thank you and a warm welcome to everyone from all parts of the world. I'm really delighted and honored that you're able to come here today for what will be a two-part webinar. This is part one, Dignity and Care, the human side of medicine. And 2 days from now, same time, same channel, so to speak, we will be commencing with part two. I thought I would start by saying, let's just, there we go. I thought I would start by telling you how this seminar came about. For some reason, I found myself receiving, as I do, requests from various people around the world to do teaching on issues related to dignity. And I noticed over the past year, there were a number of requests that were coming from India. And people were asking if I might participate in some of the teaching, some of the classrooms that they were convening. And it seemed to me that talking to small groups of people, 10, 20, 30 at a time, when one considers that India is a country of 1.4 billion people, may not be the most efficient way of trying to spread the word, so to speak, on these issues related to dignity and care. So at that time, I reached out to Pallium India and connected with Dr. Sunil Kumar, also along with Dr. Rajagopal. And we began to discuss the creation of a webinar like this, where we would be inviting people from far and wide in order to try and spread the word much broader than one classroom at a time. I also want to point out that Dr. Tareen Syed from the Texas School of Mental Health immediately came on board, was very enthusiastic about the proposal, and is being very helpful in trying to spread the word. And so that's how we arrived at today. The organization essentially has been left in the hands of Pallium India, and they've created this wonderful platform for me to be able to reach out to all of you. As you'll notice, there is no charge whatsoever to participate in today's proceedings. The only request that I have, and again, this is in the service of spreading the word, is that each of you do what you can to share whatever knowledge, whatever information, whatever insights you've learned today and again on Wednesday, to spread them as far and as wide as you possibly can, so that you and I collectively can try and raise the bar on dignity and person-centered care. Being a psychiatrist here in Canada, if you've heard other Canadians speak about palliative care, they may oftentimes invoke the work of an artist named Robert Pope. Robert Pope was a wonderful artist who lived on the east coast of Canada. And during the course of him approaching his own end of life, he created a series of wonderful and provocative paintings, really in some ways documenting his own illness journey. And although this is not one of his most commonly known paintings, it's one that I have been looking at as of late, because it seems to me what we see is somebody who is precariously afloat in water, and it gets you thinking about the various different forces, be they physical, psychological, existential, spiritual, that keep this person afloat. And those same things that may threaten to pull that individual under. And of course, during our work, we are dealing with people who are in a particularly vulnerable and precarious position. And in order for us to provide dignity and care, it's important for us to understand what is it that keeps people afloat, so to speak. In other words, that keeps people going and engaging in life as long as life itself is lasting. Um, of course, when life approaches its end, what can sometimes happen is people can feel that it loses its allure, that there's no longer a desire to go on living. And I wanted to actually begin these comments by saying how I came to understand the importance of dignity as something that has relevance for the work that we do. And the insight with respect to dignity really came from examining what happened to people who feel that they've lost their allure for being alive, that life itself has lost its allure and threatens to pull them under, which can express itself as a wish to no longer want to be alive. Um, when we first began looking at this is decades before there was any legislation in Canada around medical assistance in dying, we turned our attention to what was happening in the Benelux countries. And for example, in countries like Holland, where practices with respect to euthanasia and assisted suicide had been available for many, many years. When we looked at some of the data that was coming out of Holland, we happened upon a study that was first authored by Paul van der Maas, and this was studied or was published in the journal The Lancet back in 1991. Now, van der Maas had reported on the prevalence of what he called MDEL, or medical decisions to end life, and said that whether or not you're talking about euthanasia or assisted suicide, anywhere between 2 and 4% of Dutch patients were availing death hastening measures, which was interesting, but not the most important things in our minds in terms of trying to understand what I have referred to as the experiential landscape of end-of-life care. So van der Maas then went to the death records of all patients that he found had died as a result of either euthanasia or assisted suicide, and identified the physician of record. And there he decided that he would approach these physicians to try and find out, why is it your patient sought out this particular option? Why is it your patient chose to end their life through the means of death hastening? And this is where dignity first came on our radar, because more so than any other reason cited by these Dutch physicians, loss of dignity, 57%, was the reason that patients had sought out assisted dying. Now, notice that pain alone was not a big player, about 5%. Pain as part of a constellation of symptoms, about 49%. And then you have these other rather vague and somewhat nebulous things, such as unworthy dying, tiredness of life. But I bring you back to the finding that more so than any other reason cited by these Dutch physicians, we found out that dignity seemed to have relevance. And so we decided that if dignity is worth dying for, then dignity is worth studying. And when we looked at the literature at this point in time, we discovered that although dignity was cited frequently in the literature and was a highly politicized term that people would use to support whatever position they happened to hold on contentious issues, there weren't empirical studies that had gone to the bedside of patients. And after all, the voice of a Dutch physician is interesting, but not as critical as the voice of a patient who may be approaching death and who perhaps even may be contemplating whether or not they wish to continue being alive or not. So if dignity was worth dying for, dignity was worth studying. And we began studying dignity in earnest. One of the first studies that we published, again, this goes back now to the late 1990s, again was in the journal, The Lancet. This was a cohort of over 200 patients. And you'll notice that about half of those reported that they had no lost sense of dignity, which means that in the remainder, for half of your patients, and these are all patients who are receiving palliative care. And let me explain what that means. It means that they had a life expectancy of less than 6 months. It means that on average, they were in their early to mid 70s. And it means that about 80% of the cohort had some end stage malignant illness. Those are the sorts of people that I, along with my research colleagues, have been studying for well over 30 years. Again, in this first empirical study of dignity, we found that half of this cohort of over 200 patients said dignity is not an issue, which means in the remaining half, dignity, at least occasional sense of lost sense of dignity, is an issue for them. And in a small cohort, about 7%, it was a significant problem, at least of moderate severity or greater. Now, the details of all of these findings in my research are available in the public domain. You can go to PubMed. You also have received a handout from me that has links for many of the critical studies, as well as the option of course, contacting me, and my email is available. You can reach out to me if there are further questions. But this is just meant to introduce you to some of this material. And obviously, we're not going to be able to do a deep dive on over 30 years worth of work. But the critical finding, and for me, in some ways, this was the epiphany of this work at that time, when we went to try and find out from this study what was most predictive of lost sense of dignity. In other words, if you had to choose one thing that would determine whether or not dignity was intact or not, what might that thing be? And where the data led us, and again, this is the data. This is not we sat around and made a decision collectively. This is where the data led us. And the data said that more so than any other variable that we measured, and we measured many things, pain, anxiety, depression, appetite, and so on, this issue of perception of how people felt they were seen. The variable was appearance, so how they thought that they appeared to others. In other words, the esteem in which they feel they are held. As I say, this for me was somewhat of an epiphany, because up until this moment, I always thought about palliative care as being about the things that we do to patients, or the things that we do for families. But the data was now saying how we as healthcare providers see or perceive patients is most predictive of lost sense of dignity. So I decided to write a separate paper, which was published in the Journal of Clinical Oncology, called Dignity in the Eye of the Beholder. And afterwards discovered this etching by M.C. Escher, who is a wonderful Dutch graphic artist. And this is a self-portrait. I choose to call this Dignity in the Eye of the Healthcare Provider. And what you're seeing is a reflection of the artist. He is in his apartment. You can see he is a debonair looking middle-aged gentleman surrounded by books, photographs, paintings. In other words, this reflection is an affirmation of personhood. And if you take the time to read the article, what you will read is that although it's empirically driven, I say metaphorically, what patients are looking for is a reflection in the eye of the beholder, in the eye of a healthcare provider, that will be affirming of their dignity, that will be affirming of personhood. So this means then that how you as a healthcare provider see or perceive your patient has a profound influence on their care, which is really quite extraordinary to think about. What goes on between our ears, what we are thinking, how we actually see or perceive our patients is most predictive of whether or not dignity is held intact. And so many of the things that I'll be talking about over the course of today and on Wednesday when we do part 2 has to do with the healthcare provider gaze, how we change the way, how we at least appreciate the way we appreciate or don't others. Now, in view of not being seen, when people feel that they are no longer being acknowledged, that can express itself as the wish to no longer be alive. And certainly, desire for death is an expressing of human anguish. It is an expression of human suffering. And we, in our earlier studies, looked at desire for death. And again, in relatively large cohorts, certainly for palliative care studies, we have looked at desire for death in the terminally ill and reported that people who have a desire for death, 80% of them will have moderate pain of severity or greater. They will have the perception that their family is less available. And they will also report significantly higher prevalence of clinical depression. And I think the take-home message for you should be that if we're going to understand the wish to no longer be alive, we need to understand a multiplicity of influences. We need to understand the physical, such as pain. We need to understand the psychosocial, such as family networks and intactness of those networks. And we need to understand the psychological, example, depression. And I would add to that spiritual and existential. We went on to also study what I refer to as will to live. And will to live, we measured using a visual analog that was added to an instrument developed by Dr. Eduardo Barrera, a very esteemed palliative care clinician who developed the Edmonton Symptom Assessment Scale. Anything that scores high on the visual analog is indicative of distress. And so we added a visual analog for will to live. So a high score of will to live in yellow means a paucity of will to live. So to illustrate this, this is one case example. This is an 80-year-old woman with colorectal cancer. And you can see when she originally comes into palliative care, her will to live is poor. It immediately improves. The scores go down. It stays relatively stable throughout her hospitalization. And we took measures twice daily from the time people came into our study until they could no longer give meaningful data. And towards the end, it becomes much more erratic. You'll notice that when we superimpose will to live with her subjective reporting of pain, the two of them do this intimate tango. In other words, it appears that as her pain improves, so too does her will to live. Or it could be, because we can't talk about cause and effect, as her will to live improves, because she's now receiving the kind of physical, psychosocial, existential, spiritual support that she requires, so too improves her experience of pain. More recently, and again, if those who are curious can go to my more recent writings, I've been writing about this in terms of what I've called fractured personhood. In other words, what happens for many of our patients towards the end of life or as they become particularly ill is this struggle with, am I still me? Am I still intact? Am I still the person that I once was? And of course, illness takes away energy, it takes away vitality, it can take away autonomy. And so, or certainly dependence or dependency, or independence, I should say. And so, what I've been looking at recently is a construct that I refer to as fractured personhood. And one of the things that I'll share with you is that many of the insights that you can glean from studying patients near the end of life actually have resonance across the entirety of life. After all, people who are approaching end of life are still people. And the advantage of studying them near the end, if they have the perspective that it includes the entirety of their life. In other words, things like dignity, things like kindness, compassion, feeling like a whole person. Those things aren't something that palliative care has a monopoly on. Those things are important throughout the entirety of life. And so in the more recent articles that I've been writing, I've been wondering, could something like fractured personhood, the sense of feeling intact, not only have an influence on a loss of will to live towards the end of life, but could it have an influence on suicide and suicidality throughout the entirety of life? And so our group now has a grant to look at people who have attempted or have made or who have expressed suicidality and who are now in inpatient psychiatric facilities. And we are studying this issue, this dynamic of fractured personhood, and the extent to which it has an influence on whether or not they wish to be alive or not. So to summarize, and in some ways this graph summarizes in a beautiful, succinct way, you'll notice that at the center of this graphic is standing a person, a human being. Externally, we see students, we see healthcare providers. And objectively, from that position, we are trying to understand the physiology, the pathophysiology. As clinicians, we're trying to understand a diagnosis, a differential diagnosis, a problem checklist. But at the center of it all is still a patient, a human being with the human striving to be seen, to be understood, not only in terms of patienthood, but in terms of personhood. And certainly, if we were to have time to delve into the whole notion of human suffering, we would be talking about the dynamic of what happens when patienthood eclipses personhood. During the course of my work, I at one time published what I called the ABCDs of dignity conserving care. In other words, if patienthood or personhood is important, what are some tools to make sure that we keep it on our clinical radar? Now, many of you may be familiar with the ABCs of critical care: airway, breathing, circulation. And no matter what branch of medicine you practice, you cannot claim to be a competent clinician in the absence of knowing the importance of the ABCs. If somebody is unconscious, you cannot say, well, that is not my lane. It has to be your lane. It is a core efficiency of being a healthcare provider to take a pulse, to make sure somebody's not bleeding, the ABCs of critical care. But when it comes to the human side of medicine, we tend to say, there are no core efficiencies. Just trust yourself, be a good person, try and be kind, which isn't helpful enough. And so this is where I created and published on the ABCDs of dignity conserving care. And let me go through those because I think they expose you to some of the ideas and some of the material that I would like to share with you. And remember, These are meant to be core efficiencies, not just of the psychologist, the social worker, the spiritual care provider, the chaplain. These are meant to be core efficiencies of anyone and everyone who has contact with patients. And the reason that I underscore that, I wrote an article many years ago. And in some ways, I mean, the title was very succinct, but made the identical point. And the article was entitled, "The Secret is Out. Patients are people with feelings that matter." So if you are a healthcare provider, no matter what lane you happen to be operating in, you are dealing with patients, and patients are people with feelings that matter, which means part of your core efficiencies need to be the ABCDs of dignity conserving care. Now, they are as follows: A for attitude, B for behavior, C for compassion, and D for dialogue or conversation. So let's go through those one at a time. The A for attitude we've already sort of talked about, and I've given you the fact that this is empirically driven. Your attitude, your perception, the way you see your patient has the most profound influence on patients' sense of dignity. Not so says I, but so says the data. So says the published collective data that we have produced and introduced into the literature. So let's move on to B for behavior. Do you sit? Do you stand? Do you meet someone's gaze? Do you not meet someone's gaze? You may say, well, do those things really matter? They sound rather simplistic and intuitive. This is not a study that I did, but it's a delightful study that took place in orthopedic surgery. It is a randomized controlled trial of sitting versus standing. The protocol was, and this took place post-orthopedic surgery, the surgeons would come for their first post-op visit. Before they walked into the patient's room, they had to take a chit from the doorway that randomized them to either sit or stand. The rest of their routine was identical and was uninfluenced by the protocol. And you'll notice that when they were randomized to the sitting position, the perception of the amount of time that they were actually there was 5 times longer than they were. When they were randomized to the sitting position, the level of satisfaction with the conversation they had with the patient was 95%. Look what happens when the clinician stood. The perception of time wasn't nearly as expansive, and the level of endorsement for a positive experience was somewhere between 40 to 60%. So there is good evidence, empirical evidence, that the simple act of sitting creates a better outcome because it changes the perception of the recipient, even though the conversation doesn't change whatsoever, even though the amount of time doesn't change whatsoever. And you can see these were really very brief interactions, about a minute and a half or so. The message it gives when you sit is, I am not rushed, I am available, and I am here for you. We could have, of course, a very extensive conversation about compassion, but let me be brief. So compassion is the idea of understanding the suffering of another person, and I underscore the suffering of another person and your attempt to respond to it. My previous postdoc, Shane Sinclair, who is now a world authority on compassion, says compassion is a verb. In other words, it invokes action or the attempt to take action. But again, understanding the suffering of another person means we need to understand something of who that person is. I've told this story many times, but let me tell it again because I think it's so illustrative of what you need to take away from this. This is a photograph of Stuart Farber. Stuart Farber was a physician, a palliative care pioneer working in Washington State in Oregon. He himself, sadly, was diagnosed with a terminal condition, and prior to his death, published a number of really poignant and important reflections. One of them was published in the Journal of Pain and Symptom Management. And he said the following: with rare exception, the clinicians who treat me have good hearts, care deeply, but possess little or no knowledge of what he referred to as my thread. He went on to define that. My thread is the narrative I use to make sense of my life. It's longitudinal, nonlinear, emotional, filled with contradictions. It integrates my life experiences into a coherent whole. It is within the values and meaning of my story that treatment decisions are made. What contributes to meaning and quality is not about living longer, but living a life that is consistent with my thread. Without knowing my thread, it is impossible for a clinician to provide respectful care. In other words, if you don't understand the essence of me, of my personhood, or what he referred to as my thread, you cannot provide respectful or compassionate care. By the way, I'll stop just for a moment. Sunil, are you still able to see me, and are you able to see the slides?
Yes, yes, I can very well hear you as well as my
Excellent.
slides also.
Very good. So the D of dignity conserving care is for dialogue, the conversations. And there are many different kinds of conversations that we can have with patients, but these are conversations that acknowledge personhood. There are a whole variety of them, and I'm going to be exposing you to some of them today and to some of them on Wednesday. Now, before I continue, I think it's helpful to invoke the words of the pioneer in palliative care, Dame Cicely Saunders. She's the founder of the modern hospice movement. As many of you know, the founder of St. Christopher's Hospice in London, England. And she said, "You matter because you are you." Again, it is about personhood. You matter because you are you. You matter to the end of your life. We will do all that we can, not only to help you die peacefully, but also to help you live until you die. Now, I began thinking about that famous adage from Dame Saunders and thinking that it is critically important that we understand you matter because you are you. It underscores the importance of personhood. But what it doesn't tell us is how to invoke care that, in fact, can elicit a sense from patients that they indeed do matter. And so I began thinking, well, if somebody is in dire straits physically, we invoke intensive care. We admit someone to an intensive care unit. We provide them with life support. What happens when somebody feels they no longer matter? Feels hopeless, feels worthless, feels helpless? They require, I suggested in this article that was published a year or two ago in the Journal of Clinical Oncology, they require intensive caring. So intensive caring is the equivalent of intensive care, but no longer in the physical realm, but in the psychosocial, spiritual, and existential realm. Let me again walk you through some of the key tenets of intensive caring as a way of operationalizing what Dame Saunders described as the importance of you matter because you are you. So the first tenet of intensive caring, I suggest, is non-abandonment. In other words, a commitment to quality connection, ongoing care. Let's think for a moment. What are the dynamics of abandonment in healthcare? I would suggest to you the dynamics of abandonment are helplessness, feeling impotent, feeling I don't know what to do, and therefore people withdraw. And if you, again, invoking Dame Cicely, she said, suffering is only intolerable when no one cares. So the first tenet of intensive caring is non-abandonment. It is a commitment, in spite of whatever feelings of helplessness you may have, It is a commitment to being present, forming a quality and sustained connection. And of course, then taking an interest in that person. I should say that there are also studies. There was a lovely study a few years ago. Kelly Trevino, an American oncologist, published a study looking at trying to find out the most ardent predictors of suicidality in patients with advanced non-curable cancers. The quality of the connection between the patient and the sustainability of the connection between the patient and their oncologist was most predictive of suicidality, even more so than psychotropic medication. So even though you may be thinking, this is beginning to sound a little bit touchy-feely, a little bit soft-edged, I would say the data is profound. The data is the difference between life and death. The connectedness between that individual and their healthcare provider makes the difference between wanting to be alive and not wanting to be alive. So the first tenet, if you are entering into a space of a patient who is feeling abject suffering, I no longer matter, the first tenet of intensive caring is to show up. Non-abandonment. And of course, what do you do if you show up? Well, you need to take an interest in that individual as a person. That means you need to be respectful, you need to be connected, and you need to provide, and I don't think we hear this word used sufficiently in medicine, affirmation. Affirm the worth of who they are, who they were, who they try to be, and what they try to accomplish in this life. So how do you do that? Well, there are various different ways that you put personhood on the radar. And most of you, of course, just do this intuitively by saying hello and finding out who they are or how their family is or whatever part of your routine is to find out about personhood. We in our work have introduced a number of ways of trying to do that. Dignity therapy is one of the most studied psychosocial, psychological interventions in palliative care today, and it's based on generativity and creating legacy. And I'm not going to say anything more about it today, other than to tell you that it is going to be largely the focus, not the exclusive focus, but largely the focus of part 2, which will begin on Wednesday. So it is one way, certainly not the only way, of putting personhood on the clinical radar. Now, a much briefer way that we have discovered and that we have introduced into literature is something that we call the patient dignity question. And the question reads, what should I know about you as a person to help me take the best care of you that I can? And there is the Hindi translation, and I hope it is correct. How does this protocol work? We go to the bedside of a patient and say something like, we know a great deal about your physical circumstances. We know all of the things that are on your chart. We know less about who you are as a person, as a human being. And the PDQ reads, what should I know about you as a person to help me take the best care of you that I can? And again, I underscore the importance of the words as a person. Now, this then is meant to elicit a conversation, a brief conversation, 5 minutes, 10 minutes, 15 minutes at most, but it's focused on personhood. In other words, it says, if you are allowed to choose the lens through which your healthcare provider sees you, this is your chance to shape that lens. How do you wish to be seen? How do you wish to be known? We have this conversation. We go off and we summarize it into a few paragraphs, and then come back for 3 things. One is to read it to the person. The second is to see whether or not there are any editorial changes they would want to make. After all, this is their story, their lens. And then the third one, and this is the litmus test, would you like this placed on your clinical chart? And I can tell you in my experience, I've never heard a patient or a family member who have refused, who have said, no, I don't want people to know that about me. Because after all, we've asked people, what would you like others to know about you as a human being, as a person, so they can take the best care of you possible. Again, because of time, I'm not going to go through all of this in detail. These are the results of one study we did. There are now thousands of patients who have been studied and reports in the literature on the patient dignity question. But what you can see from this study of about 125 patients is that all of the patients, or the family member, by the way, said this was accurate. All of them, without exception, and these are just rounding errors, said, I want this on the chart. Many of them wanted a copy for themselves. They thought it could be important for their healthcare provider to know. They thought it could change the way that their healthcare provider might look after them. And then finally, all of them, without exception, said, this is something that all patients or all families should have available to them. Now, by the way, I mentioned families because what we have discovered is that the PDQ, the patient dignity question, works very well, whether or not the informant is the patient, or, and I remember circumstances where, walking into the room, and I can see it as clear as day, an image of a woman, elderly woman, no longer conscious, of course, no longer able to respond to this, but she was in her bed. She was surrounded by several of her children. And I sat down and I said, so what would you want us to understand about your mother, as a person, in order for us to give her the best care possible? And the families are able to answer that in very clear ways and in ways that are comforting not only to them, but provide critical information for the healthcare team to know domains of who this individual is beyond whatever physical ailment brought them to our clinical attention. I can also say that when we have gone and spoken to healthcare providers, because the healthcare providers, of course, are the recipients of this information. After all, we are trying to change their lens. Think back of that image, how healthcare providers see their patients. Well, one of the ways that we manipulate that lens is with information about personhood. And you can see in 90% of instances, they say, I found out something I didn't know before. Remember, all of this information took place or was elicited from healthcare providers in palliative care, who tend to be wired for empathy and compassion. And you can see anywhere from 50 to 65% still said they were emotionally affected by it. It influenced their attitude. It influenced their care and respect and empathy and connectedness. Now, during the course of COVID, this was a particularly difficult time, well, for the planet, really, but certainly for patients and for families, especially considering that families were no longer able to be there at the bedside of patients, both to support them and to make sure that the healthcare team had a clear understanding of not only the physical domains of that individual's experience, but to make sure that personhood didn't fall off the radar. So we did a PDQ study that took place in the intensive care unit. What this simply meant is that the intensivist who was looking after the patient, and all of these patients now in this study of about 35 people, all of these people were either unconscious or they were on a ventilator fighting for their life. The intensivist would ask the family member if the healthcare research team could contact them. With their consent, we contacted the family, usually at home because of public health restrictions, and said, look, we know a lot about, your mother, your father, your sibling physically, but they can't speak to us. So we don't know anything about who they are as a human being. And then we asked the PDQ question. So tell me about them, your family member as a person, in order for us to take the best care of them possible. And then we would have the same brief conversation that we would summarize, call the person back, read it to them, and then with their consent, place it on the chart. So this is actually a paragraph from one of the PDQs. Terry was the daughter of a woman who was a First Nations a woman who is now on a ventilator. And the PDQ paragraph reads as follows. Terry says she wants the healthcare team to know that her mother is not an ordinary patient, but is a very special woman. Since my mother was admitted, I have been struggling to find a way to share my mother's story with the staff, but my heart is so happy that this PDQ will now allow me to do so. I hope the staff read my mother's story and appreciate the life she lived. And off to the side here, you can see that we also have tried to quantify their results by getting them to fill out some Likert scales from 1 to 5, 5 being the highest endorsement. And the only thing you should notice is that all of these numbers are as close to 5 as conceivable. In other words, in every instance, they said this needs to be placed on the chart. That it was accurate, important information for the healthcare provider to know, that they thought that the summary might affect the way their loved one was cared for. They thought this is something that all families in these circumstances should be offered. And I can tell you from personal experience, and the data substantiates this, all of them found this a deeply emotionally meaningful and moving experience. And I can remember people crying on the other end of the line because they were just so overwhelmed with the opportunity to now tell us, who are part of the healthcare team, who this person was, what they meant to them, why they wanted us to see them, not just as somebody who is struggling for life on a ventilator, but as a mother, a father, a sibling, a friend. The PDQ has now been translated into over 20 languages. I don't expect anybody to be able to read this. I gave you the Hindi translation. But in some ways, what this says to me is there's something kind of a fundamentally human about what we're talking here, even though all of us come from different corners of the world. And of course, there are cultural nuances. The idea of wanting to be seen, wanting to be known, wanting to be respected on the basis of personhood, and for personhood to not be eclipsed by patienthood, it seems to me by the uptake of this is universal and really speaks to kind of part of our shared humanity. Now, if we're going to, again, take seriously the gaze of the healthcare provider, we need to think, what shapes our response to individuals who come into our care? And I think many of us, and it makes good sense, many of us, of course, trust our intuition, which means we evaluate the situation, and oftentimes we defer to what we would refer to as the golden rule. Geez, if this were me, if this were my family member, how would I want myself? How would I want them treated? In other words, doing unto others, you would want others to do unto you, which is an important adage that you see in religious tradition across millennia. But there is a limitation of the golden rule, and that is we have to acknowledge it does impose this external standard. So, and what I mean by that is that we are making an evaluation based on what we think we would want, what our family member would want. And of course, that may lead in some instances to therapeutic nihilism. I don't know if I want to be that sick. Would I want to be that old? Would I want to be that disabled or that disenfranchised or that dependent? So it could then see you offering advice based on avoiding a future that you, the care provider, would find untenable, which of course then can lead to discordance regarding goals of care, which made me think, well, is there a different standard? Is there what you might think of as a higher standard, which I refer to and have now published on the Platinum Rule, doing unto patients as they would want done unto themselves. So let's talk about that in a little bit of detail. And I'll illustrate using, I've now published 2 papers on the platinum rule. The first one was in the Journal of Palliative Medicine, and the second one was in JAMA Neurology. This is a copy of that picture, and this is a picture of my late sister, Ellen Chochinov, who died at the age of 55. Ellen was born with cerebral palsy and had many of the challenges that somebody born with that condition might have, both physically and emotionally. This particular story that I tell in this article took place several years before Ellen's death. Because of her cerebral palsy and kyphosis and scoliosis, her lung capacity was terrible. I can't remember if I said it in this article, but I've certainly said it when I've told the story. She could not blow out birthday candles if her life depended on it. So in this story, Ellen again found herself admitted to the hospital, this time admitted to the intensive care ward. And the intensivist, I recall, and tell in this story, was pacing about the ward, trying to determine what his next move was. And things were looking very serious, and her blood gases, I imagine, were dropping. And the intensivist was on the brink of having to make a decision as to whether or not she would be intubated, whether a breathing tube would need to be inserted. And so he came over to me and asked me the only question that he was to ask about the issue of personhood. And that is, can she read magazines? And at the time, I remember thinking, this is a very serious thing we're going through. Why are you asking me something so inconsequential as, can she read magazines? And then it occurred to me that there was subtext here. What he was saying is, she is shaped in ways that are so distorted, so aberrant. And what he was essentially trying to determine is this the kind of person in this situation? Is this somebody that we should be intubating? And so I realized in that moment that life and death was hanging in the balance, that he was able to see her kyphosis, he was able to see her blood gases, but what he wasn't able to see, and that's the reason the title of the article is called Seeing Ellen, what he wasn't able to see was my sister, and to understand her complex but very rich life that she led and that she valued. And so I said, well, yes, she is able to read magazines, but only when she's in between novels. So, why is the platinum rule important? It's important because it means we have to remove ourselves or somehow check our own biases and think about considering the perspective of that individual, which, as I say, then helps us to recognize and confront personal bias and raises the bar on person-centered care. It also, by the way, is an important standard for substitute decision-making. We know if you're standing by the bedside of somebody who can no longer speak, the appropriate question is, what would you want us to do now for your mother, for your father, for your sibling? The appropriate question is, if we could bring them into this room the way they were a week ago or a month ago, what is it that they would want done? That is a platinum standard, and that is raising the bar on person-centered care. So the next tenet of intensive caring is what I refer to as therapeutic presence. This is a way of your being in that space of somebody who feels they no longer matter. And it's not about what you say, it is about your, and I don't know a better word than aura. I remember once describing this to an oncology nurse, and she said, oh, I call that the fragrance of care. In other words, it's the experience that people have of you just by your presence. And it's based on, and again, the elements of presence comes from a study that we did looking at communication. It's about being empathic, non-judgmental, authentic, trustworthy, being fully present, non-distracted. And again, I think that's why we have those profound findings in the orthopedic study where somebody sits down and suddenly the perception is you are here and available for me, and you're not distracted by the many other things that you might otherwise be doing, even though the actual amount of time available that you'll notice from that study was very short. People often say, well, we can't do this because there isn't sufficient time. Time is lovely when it's available, but what's also critical is tone of care. So presence. And we know from our experience and from that study that we can change even perception of time when we deliver the message that we are fully present for you and not distracted. The next tenet of intensive caring is containing and holding hope. This is a particularly complex but yet rich area. What I can say is that people who feel they no longer matter, people who feel hopeless, that feeling is contagious. Families begin to feel it. Even healthcare providers begin to feel it. Like, I don't know what to do. If we lose sight of that, then we end up colluding with patients' hopelessness. So we need to understand what is possible to do even in the presence of somebody who feel life no longer matters. And it has to do, and trying to hold that hope, understanding that even in brief time, relationships can be mended, time can be spent in helping to prepare families for a time when their loved one will no longer be here. We have even discovered that one of the things that happens near end of life is that patients can actually model how to die. Although I won't go into details now, I'm doing a study with one of my postdoc students, and we are looking at trying to understand why people have made requests for medical assistance in dying. And recently, I remember one of the cases that we saw was a gentleman who told us, and this is a gentleman who'd been approved for medical assistance in dying. And when I asked him, so can you help me understand what has led you to this decision? He said, I am not going to die the way my grandmother died. And then he described his grandmother's death that was very difficult, and symptoms obviously weren't well attended. And then I said, well, I'm curious, how long ago did your grandmother die? Now remember, this is a man who's now in his late 60s, early 70s, advanced illness, and he has been approved for medical assistance in dying. He's just waiting for his date. And he said to me, well, my grandmother died 30 years ago. I just about fell off my chair. It underscores the fact that how people die leaves an imprint that will resonate not just across years, but across decades. So we need to understand that even towards the very end, people can model how to die. And it's a time, of course, for connection, to provide comfort, forgiveness, and goodbyes. And again, we could discuss it in much more detail, but because of time and wanting to leave time for question and answer, I'm going to move on. The next tenet of, and I believe this is the last one that I'm going to touch on today, is what I called therapeutic humility. That is, being able to tolerate ambiguity, accepting and honoring the patient's expertise, trusting the process, and avoiding the need to have to fix. This is a quote from the article. It says, therapeutic humility sees notions of fixing yield to commitment to understand the nature of the patient's suffering while creating a safe space to bear witness, to validate and comfort always. So think about it. Most of the time when we enter into the clinical arena, we do so with the thought in mind that we may have a way of addressing whatever ails that individual. When you enter into the space of intensive caring, you need to understand that whatever is going on with that individual, there are many domains of suffering that are no longer amenable to fixing, but we can be with. And that is, in fact, what therapeutic humility demands: being with and understanding that showing up in that space makes a difference. And so, let me just summarize some of these core tenets of intensive caring by saying this. This is a shift in the traditional medical paradigm. When you went into medicine, when I went into medicine, we did so because we were thinking, what a wonderful profession. I will be taught how to examine people. I will be taught how to diagnose what is wrong with that person at that point in time. And then finally, and how seductive, I will be told and learn how to fix whatever ails that individual. And again, I'm not being critical of that. I mean, I think it's glorious when that paradigm works. But anybody who does this work long enough, and if anybody who is in medicine long enough, or just simply lived life long enough, immediately confronts, or eventually confronts, I should say, that not everything in life lends itself to examine, diagnose, and fix. So the shift in paradigm says in intensive caring, examination yields to finding out who is this person. Diagnosis yields to trying to understand the nature of their suffering. And then fixing yields to showing up, being with, and providing comfort. So the article ends by saying it's been more than 50 years since Dame Cicely shared the wisdom informing this clinical approach. Decades later, when medicine's reached to fix its grasp, it is time to consider the role of intensive caring is now. So before I finish, let me leave you just with a few comments, and then we will have time for question and answers. Every year, our medical school has something called a white coat ceremony. And the Dean of Medicine, you can see, is here wearing a very spiffy orange tie. Our Dean of Medicine loves to wear colorful bow ties. He invited me last year to give the white ceremony address. And this is a chance to speak to all of the incoming medical students. They are there in the audience. And I'm looking out right now at an audience of several hundred students, along with their family and friends. And this is meant to introduce them to medicine. I'm not sure what I take more pride in, the fact that the dean asked me to deliver this speech, or that I, at my ripe old age, was able to figure out how to make a QR code and embed it into a PowerPoint presentation. Anybody interested in hearing my full speech, this is the QR code that you need, and feel free to go there at your leisure. But let me close today's session by giving you a few quotes from what I said to the medical students. And I told them this. I said, strive to be more than human body mechanics. Aspire to be healers. I next said, the way that we are with patients and our attitude towards them will profoundly shape every single clinical encounter and their illness experience. I next said, and I say to you, patients will not care what you know until they know that you care. And then finally, and in closing, I said, in exercising kindness and compassion in every clinical encounter with every person whose path you cross, you are playing your small part in bending the arc of the universe towards hope, healing, and peace. So with that, this is my book. This is the email that you would have to address if you are to get the special low-cost price that was, and this was just released, and it's available to colleagues in India, Bangladesh, Sri Lanka, Nepal, and Bhutan and Myanmar. This is how you get hold of me. Feel free to follow me on social media. And just before I stop sharing my screen, and before we start the Q&A, I'm going to, I can stop sharing the screen as people have taken down my email address in case they need to get hold of me. I will stop sharing. But before we open up the question and answer, what I would like to say, there we go. What I would like to say is this: we are meeting in 2 days. So you all should have received some handouts. In those one is a copy of the article on intensive caring, and I hope you read it at your leisure. I think it is interesting and provides a way of trying to do work and enter into a space that many people find very challenging. How do we address people where we don't have a readily available solution? So the three things, though, that I would like you to think about and perhaps undertake between now and Wednesday. One is, you will see in your handouts a copy of the patient dignity question. Think about asking some of your patients this between now and then. I've occasionally had people say, well, I tried it and it didn't work. Well, I would say, understand this. It is meant to be the beginning of a conversation. And the reason that people may not understand is that oftentimes people do not think of this as being something that we talk about in medicine. So when people say, well, I'm not sure I understand what you mean, you say, well, I think it would really be interesting and helpful for me to know who you are as a person. I've been looking after your physical needs. I've been looking after your physical health. But I think it might be helpful if I understood who you were. So that's the conversation that asking the patient dignity question is meant to elicit. And I would say, try it. You're under no obligation, of course, and we're not going to have time to get feedback, although I will invite you to enter into the chat, and perhaps this is something that Dr. Kumar may be able to make available even after our session is finished. If the conversation is to continue, share your experience of that. The second thing that you might think about doing, next week, although not exclusively, we're going to be talking about dignity therapy. You'll notice in the handout, under the section called Dignity Therapy, there is a URL for a story called Bruno's story. I think it's only 7 to 10 minutes. It's a wonderful video made by colleagues in Geelong, Australia. And it tells the story of an actual patient, a man named Bruno. I think if you watch it between now and then, you will come to the session with a much more informed idea about what dignity therapy is. And then finally, and again, this is only for those who are keen and how much time you have, you don't as yet know how to do dignity therapy. I haven't explained that, but the dignity therapy question framework is included in your handouts. Look at the questions. Think about whether or not there is somebody in your life. It may be a parent, it may be a senior that you know, it may be somebody who's feeling particularly ill or vulnerable. Think about having a conversation and just trying some of those questions and see where that leads you. We now have almost 20 minutes. And at this point, I'm going to turn it over to Dr. Kumar, who's going to monitor the chat and who's going to moderate the question and answer. Again, thank you all for your attention, and thank you for being part of this webinar series.
Thank you, Dr. Harvey, for this wonderful session. And I think I can see a couple of questions in the chat. I will read it for you. And this is by B. Ming Tan. And the question is, thank you so much for great presentation. I'm from one of the Asian countries, Malaysia. I often find when talking with my palliative care patients or family, questions like PDQ, spiritual issues, or even about their own feelings are topics that they do not expect physicians to ask, or not something they are used to express, hence leading to a lot of surprised expressions, sheepish smiles, and unanswered questions. Just wondering, cultural differences were something observed and the ways to facilitate the exploration.
What a wonderful question. Now, I could only hear some of it, but if I understand the question correctly, uh, it's the idea that in my community, in my culture, it is not typical that a healthcare provider would take the time to ask about personhood or spiritual issues or any of those things. And I think the questioner is saying, so what do we do with that? How do we broach that? Um, I would say to do so with humility, and to do so with a gentle touch. Um, I'm not trying to claim that we can parachute in and anything that we've learned, for example, from North American experience, immediately translates and translates well and perfectly cross-culturally. Um, but one of the things that I've noticed over the course of many decades, and I've traveled around the world, is that people are people. Um, all people have their own story. All people want to be respected, want to be understood. And people oftentimes suffer when they feel like the uniqueness of who they are is somehow dismissed, is somehow not acknowledged. So I would say, if this is especially new in your cultural context, to start slowly, to start in a gentle way, and even to take a moment to identify what you're doing as something a little different. So you might say, I know that normally, you and I talk about and by the way, something I didn't say, although I'm a palliative care researcher, I think everything that I've said applies across all of medicine, right? So acknowledging personhood, I am now seeing references to my work in areas of medicine that have nothing to do with palliative care. So what I was going to say is that introduce what you're doing as something a little bit different. And you might say something like, I've been looking after your COPD, chronic obstructive pulmonary disease. So you and I have really been focusing on your illness and all of the things that we've been having to do to understand that, to get under good control. But I think it might help me if I understood just a little bit about who you are as a person. Now, I've had the experience where people say, "Well, I'm not sure. I'm not sure what you mean," or they begin to talk about something that is more in the physical realm. I remember one gentleman who at first just didn't get it. He said, "Well, what you need to know is I'm worried about leaving hospital. I'm worried about the stairs in my house." Well, I'd say, "Yes, those sound like very important concerns," but I persisted. I said, "Well, you know what? I know this is a bit of a different conversation. I think it would help me if I understood who you were as a person." And then his wife, who was listening, and I think English was a second language, his wife, who was listening, says, "Oh, I understand. You want to know who he is." And then she proceeded to tell me he was the person who everyone in the neighborhood came to for advice, or he's the person who would fix things when they were broken, or he's the person who was a member of the choir. So I would say, if this is particularly foreign and atypical in your culture, be humble, be gentle, but be transparent. Say, I know this isn't usual, but I think it might help me if I understood a little bit more about you as a person. Um, and again, in my travels, I mean, I've never met people who said, my values don't matter, and the things that people tell you when you ask about the PDQ, it may be, I was a doctor. I experienced trauma in my life. I have people in my life who count on me. One woman who was dying who said, "My death is not a tragedy, but my son is dying of pancreatic cancer in the hospital across the river, and I'm worried about him. I'm worried about his wife, my daughter-in-law, and my grandchildren." So when you ask the question, you end up finding things about people that really speak to their values, to their core, as Stuart Farber said, their thread. Um, let's see where that takes you. Maybe, again, feel free to enter that information into the community conversation that Dr. Kumar has set up for this webinar and share your experience. And it might be a way of us collectively to be able to see where this experiment, so to speak, leads us. Thank you. Wonderful question.
Thank you, Dr. Harvey. So, um, from um, uh, this question is not usually asked in some cultures. So, maybe as Dr. Harvey said, you can tell the patient that, uh, uh, can I have the permission to ask a question which is not usually being asked during a consultation, and then you can have this question about personhood.
I'm
Uh,
sorry. Could you repeat that just one more time? I didn't quite hear it.
Yeah, I was telling that in cultures where this question is not being usually asked, then maybe they can signpost this question by telling that, can I ask a question that is not usually asked during a consultation? And maybe then this question can be introduced. The patient dignity question.
Again,
think
I'm not sure if I'm
Yes.
understanding it at all. But again, I think that the issue of humility, being gentle, of being transparent, and again, when although I introduced this as the patient dignity question, what we're essentially saying is there a way of being able to find out something about who is this person? I mean, patients, after all, are people, and finding out who people are is part of what it means to be a healthcare provider and what it means to be a healer. I'm seeing Dr. Raj, who looks like, and I'm not sure if I'm mistaken, but I think Dr. Raj also has a comment perhaps that he wants to make in response to that.
thanks, Harvey and Sunil, and thank you, Dr. Wayman from Malaysia, for the particular question. I I wanted to come in and make a comment, particularly because I've heard the same thing from a young doctor working in the hospital. The problem is, as the doctor says, it's so out of the ordinary, and there are a few things that matter. Are you standing up and looking down at the person? Have you been talking only about the body and organs and diseases till that moment, and all of a sudden you bring this in? They will think it's strange. I would say the first step is to sit down. Sitting down is huge, makes a lot of difference. Sit down there. Maybe don't be afraid to hold a hand and say a, an empathetic statement like, "You seem to be in a lot of pain. You look anxious. You seem to be suffering. Would you like to talk more about it?" And those conversations are followed by this question. Then it will be natural. It won't something strange voice from another planet.
Exactly. Thank you, Dr. Raj. Great wisdom as always.
Thank you.
Dr.
So,
Kumar, I see a question in the chat about countertransference and dealing with the death of a patient that one was connected to. Do you want me to respond to that?
Yes, please.
Yes. So for those of you who haven't seen the question, Ananya, and I hope I'm pronouncing that correctly, has asked us, curious about to navigate situations where possible countertransference, when we start to ask about personhood. And I think a part of that is, what about then, we feel this sense of connection, and how do we deal with that when someone has died? So this is a really, and thank you, Ananya, for that. It's a really important question. Sometimes, you hear people intuitively say that, the way to deal with suffering is to try and protect yourself from it, to not get too close to it, because you yourself may feel overwhelmed with the patient's situation. And if you can deal with people in a more kind of transactional way, deal with their physiology, deal with their laboratory results, and not the human side of care, emotionally, although you're not as connected, that also may serve as somehow protective, that you're not going to be as emotionally involved and therefore as emotionally vulnerable. That's the rationale for sort of keeping distant, and for not being involved in intensive caring, because intensive caring means showing up, it means being there. What our data has shown is that when the people who avail themselves of personhood information, our findings actually reported a heightened job satisfaction, which is interesting, because what happens is that the people who actually avail themselves of personhood information end up reporting that the job itself becomes more satisfactory. And I've spoken to many a clinician who says, the physical parts of caring become very routinized. It is the human interaction where the real skill of being a provider comes. So I remember I had a colleague once who said, doing this kind of care, it's sort of like if you're going to enter into the kitchen, you need to be prepared to feel some of the heat, but not stand so close that you stand to be burned. So I think what is meant by that is that when you avail yourselves of this kind of information, it allows you to be effective in ways that you previously couldn't be. When I'm with somebody and I find out something about them that allows for a connection. In other words, that woman I told you about who said, what I'm really worried about is my son who's dying, and what will happen to my grandchildren. Of course, I can't change the fact that her son is dying, and that her grandchildren are going to now lose a father. But I can sit with her and talk to her about that and what that experience is like for her. And in that moment, she feels understood. And I have provided something that perhaps another healthcare provider wouldn't have taken the time to provide, which is, I see you and I understand what you're going through. We do the same thing when we arrive at a home of somebody who's died for their family member. We can't change that they're bereft, but we can be there. We can bear witness. And so I would say that first off is to understand that doing this kind of work in and of itself is interventional. It is meaningful. Perhaps not in the traditional way that we understand making a difference is, but understanding, showing affirmation, making sure the patient feels seen is doing something. And then, the issue of, and then, of course, people die. And how do we deal with that? I tell families, follow a path of no regret or of least regret. I think as a healthcare provider, I think it's good advice as well. If I can know for that patient who has died and was worried about her grandson, that I was able to give her a feeling of being known, of being seen. Or the gentleman who said, well, I want people to know that I was a physician. to be able to say, oh, okay, tell me about what it was like to be a physician. If I know after the fact, after that person has died, that I've provided them the kind of care that was optimal, I find myself in my own sense of loss feeling like I am walking a path of least regret, that I didn't leave unsaid or unseen what needed to be said, what needed to be seen. The other last thing, of course, is that um, this kind of work demands not only book knowledge and technical skill, but as well, it requires an emotional bandwidth. And if you are going to be putting your emotional bandwidth out there as part of what happens between you and patients, then you need to look after that. You need to, and that means self care. It means attending conferences like this where we can talk about those things and acknowledge those things. And it also means collegial support, that you talk to your colleagues and you debrief about these issues, not only about, well, you know, the antibiotic we used or the chemotherapy line of care that we invoked, but we talk about what it was like to look after that person, because that is our way of making sure that our emotional bandwidth is intact, is healthy, is being nurtured, is being looked after. What we know from the literature is that emotional disconnection, becoming robotic, makes you vulnerable and at risk for burnout. So the opposite of that is saying we need to be emotionally involved, but involved in a way that is going to be helpful to the patient and as well is going to acknowledge that our emotional bandwidth needs to be cared for. Thank you, Anya. Wonderful question. I think that brings us to the end of the session, and I'll turn it over to Dr. Kumar for some closing remarks.
So, Dr. Harvey, there are some questions in the chat, but I think I will mail it to you all the questions so that you can take some time to answer those, and I can post it in that group. But considering now it's 8:30 p.m. in India, I think we can wind up the session. Um, so. Um, so we had the first session on dignity, and Dr. Harvey started with a painting by Dr. Robert talking about the different aspects of that person. And he said that 50% of patients has loss of dignity. And for that, he introduced the concept of ABCD, that is attitude, behavior, compassion, and dialogue. Then he brought the concept of intensive care. Um, there are many points, including non-abandonment, and he talked about patient dignity question, which is very important. What should I know about you as a person for giving the best care to you? And he then introduced two concepts. One is golden rule about the dignity, and then the platinum rule. And he also talked about the therapeutic presence, holding or containing hope, therapeutic humility. And he reminded us to see a video that is Bruno's story. Uh, and if you get time, you also go through the article which was shared in the group. So, uh, thank you, Dr. Harvey, for this wonderful session, and thank you all those who has joined from all parts of the world. We'll see you on Wednesday for the second session. Supriya, it's over to you.
Sunil, thank you. And again, I also wanted to express my thanks to you, to Dr. Rajagopal, to all of those who have organized this. You have my email. If I haven't answered your question, think about asking the patient dignity question. Think about watching Bruno's story. Think about a dignity therapy conversation. And next week we will talk about dignity therapy and the patient dignity inventory. And I'm looking forward to it. Thank you again, and good night.
Thank you, Dr. Harvey. We do know that you might be having a very busy schedule ahead. Still, you found out time. You explained things so beautifully to us. Thank you so much. Thank you, all the participants, for the active interaction. And with the promise that we'll be meeting again on 26 with the next part of this webinar, this is Sri Priya, along with Dr. Harvey Max Chochinov and Dr. Sunil Kumar and Dr. Rajagopalama, signing off from the Pallium India, sir. See you in the next session, everyone. Till then, stay connected. Keep spreading happiness. Bye bye.
Bye bye.
Bye.